So Saket, thank you so much for joining me this morning for a Corona Conversation. If you can maybe just introduce yourself, tell people what you do for a job and where you are at the moment and what city you live in.
Okay, yeah, morning. Thank you for inviting me to participate. I'm Saket Priyadarshi. My job title is the Associate Medical Director of Alcohol and Drug Recovery Services across the Greater Glasgow and Clyde Health Board. I am based in Glasgow, usually in my office, but today I'm in a clinical setting in the homeless health services in the city centre of Glasgow, where we deliver a whole range of services to the most vulnerable people in our city. But this is where we've cited the Enhanced Drug Treatment Service, which provides the heroin-assisted treatment service, which we launched just a few months ago.
What amazing timing. I'm really pleased that we've got someone who has a particular focus on the homeless populations, because I think one of our greatest concerns is that it's that group who are already marginalised and vulnerable. The impact for COVID on them is potentially huge. Before you go into the impact on people using drugs and alcohol, can you just give people a sense of what life is like in Glasgow at the moment?
Well, life here is as surreal as it is across the UK and most parts of the world at the moment. So as you know, as part of the UK government and the Scottish government's corona virus management plan, we're in lockdown really, or where most people are at home. So it's only essential workers and the children of essential workers who go to school. We're allowed out for shopping and exercise, essential shopping and exercise purposes only. So the streets are very, very quiet, which is a delight for somebody like me who's a cyclist. And so I'm cycling to and from work. The shops are all closed. It is eerie in the city centre. So yeah, we are trying to live our lives and run our services in that environment at the moment. It's something that I'm sure is happening across the world.
Absolutely. So tell me about the impact on vulnerable marginalised groups who are using drugs and alcohol in Glasgow and across Scotland at the moment. What's been the impact on them?
Yeah, well, the answer to that is I'm not 100% sure because actually our contact with the most marginalised populations has really reduced very significantly since we've started this lockdown process. A couple of reasons for that. One is that many of our services, where we obviously have huge amount of daily contact with our patient populations, we have gone into our contingency plans to deal with our reduced staffing level now, to deal with the need to support our service users in terms of social distancing, and then of course their own self-isolation and shielding needs. And many of them do have shielding needs as well. It means that the usual services we run have really retracted into really core essential services, much of it done on the phone. There's very little face-to-face work done at the moment. In terms of the homelessness and the city centre vulnerable group, particularly, for example, people who inject drugs in public places, etc. Again, many of the outreach teams who are contracted to run services in the city centre have found that they don't have the staffing levels to deliver those services. Okay. And so we're really in a very sort of difficult situation where our capacity to reach marginalised groups has shrunk very significantly. So we're trying to keep some of that going up. Some of the issues that we are hearing from the activity that we have is there hasn't been any significant reduction or disruption of the drug supplies chains into the city. So heroin and cocaine use or availability seems to be there as much as it was before. we're hearing that perhaps the supply of some of this tablet medications, such as street blues or etizolam, which is what's used in Glasgow, they may have started to reduce. And so within the street population, there's some presentations of people, I suppose, in a more agitated, perhaps angry state as well. Excuse me. There's been a huge response in terms of getting people off the street and into some form of emergency accommodation, and actually it's been really successful. So over the years, we've built up really good intelligence on who is sleeping rough, where they're going to be, and a partnership between the Health and Social Care Partnership and third sector has been very successful in meeting those individuals and getting most of them off the street. And that's been helped by new monies from Scottish Government, which has allowed the third sector to purchase hotel beds in the vacant city centre hotels. So
the
we're
very
actually
basic things of providing someone with shelter has been addressed. You've said that services have shrunk due to resource issues at a time when, of course, the need is perhaps greater than ever. I'm just wondering what the response has been for those people who are on scripts, for example. Are you extending the amount of unsupervised doses? Are you, make
so that has been sorry, Adam. So
threshold, even lower threshold?
Yeah, so part of our contingency to manage a reduction in our own capacity, but pharmacy capacity as well, which has been severely impacted on, as well as supporting social distancing. You're trying to avoid people congregating at clinics and also at pharmacies and outside pharmacies. What we started doing was increasing the length of our prescriptions, so people who we might see fortnightly or even weekly, we are really changing our risk threshold for now, increasing their prescriptions to 4 weeks, which is the legal sort of maximum in Scotland.
That's unsupervised doses?
No, I'll come. I'm just coming to the supervision. So Glasgow has a history, or Greater Glasgow and Clyde has a history of quite stringent supervision around, particularly around methadone. Mm-hmm. So, but we have had to really relax that, and I think what we're doing is a lot of our patients who were previously on daily supervision are now getting weekly supervision. We are asking our staff to risk assess everybody, and so we do recommend things like daily dispensing without supervision, twice or 3 times weekly supervision if concerns are very significant. And we are also making provisions, as I'll explain shortly, to actually run our own pharmacy supervision for people who really need 7-day supervision or need more supervision than 2-3 times a week, and I'll explain that to you in a little while. But that's been a huge, our practice has really turned on its head in the space of a week, 10 days. And we are under immense pressure from pharmacy that even that is too much. Supervision is more than that they can cope with. One of the challenges for them is not just that we are asking them to supervise, but also primary care colleagues are prescribing a lot of medication as contingency for their patients as well. So pharmacies are doing a lot of 2-month prescriptions, etc., for primary care to make sure that people have their medications at home. There's a lot of, I think the public are stocking up as well. So pharmacies are practicing social distancing, only 1 or 2 people allowed in at a time. But with that level of demand, they are struggling. Their capacity in terms of staffing is low. They've reduced their hours that they're actually operational. So they are pressurizing us understandably from their point of view, to even reduce the amount of supervision, the very little supervision that we're doing. And another issue that they're raising is their own COVID risks in terms of, supervising somebody, the destruction of the plastic cups, etc., the exposure that the staff feel in the absence of, and their uncertainty around PPE, around that. So it's a very dynamic situation.
But it is so strange that in the space of 2 weeks, the risk of methadone diversion and overdose just gets blown out the window by the risk of COVID, not just to people who are using, but to everyone involved in delivering service.
I mean, yeah, it's a surreal time. So I think COVID measures are a general whole population approach, yeah. But within the whole populations, there are subpopulations, of course, and the unintended consequences or the adverse consequences are probably more felt in some more felt in some groups than others. Yeah.
But things like the NSP and access to naloxone, all of those things are still available and
yeah. So NSP. So we've got our injecting equipment providers still functioning. What I'm hearing is what we've said to our drug users is take 2 weeks supply. If you want, take as much supply as you want. Don't go regularly, but take extra supply. Naloxone. We have been issuing naloxone as part of our prescribing contingency as well. We have a very large number of people trained up in naloxone. They don't always carry it. But if people are staying at home now, are they going to be using on their own?
Yeah.
What do we do with if they're staying with family members who maybe don't know that they've got naloxone? How do we have those conversations about saying, well, in this situation, you might want to let somebody in the house know and be involved in the naloxone discussion. Yeah. All that stuff is going on. Very tricky, and also trying to do it rapidly while staff have a multiple of other contingencies to deal with. Another thing, for example, is taking ORT to people at home who are in self-isolation. There isn't really a system to do that, so it's falling on our staff to do that. And at the moment,
Uber yet?
Sorry?
You haven't enlisted Uber yet?
No, but actually, a whole range of issues are rising around, safety of staff or safety of whoever is delivering. That we have issues about. We've had an incident of our staff member being really, let's just say, badly treated, going to the front of a pharmacy queue to do this. We've had one incident of social disturbance in a pharmacy queue where people who are coming out with their methadone were then assaulted by people waiting for them, because it's quite a valuable commodity for many people, or a desirable commodity anyway. So all that dynamic is going on at the moment. Now, the issue for me is that, it's very difficult at this time to understand the real impact of all that. I've had one clear drug-related death linked to the unsupervised dosing, but I'm expecting many more.
Okay.
Yeah. We've also got concerns around children in households. Yeah.
With safe storage, etc.
Yeah. So, but safe storage is one thing, but if people who you wouldn't normally think are appropriate for managing methadone, even with safe storage, are now getting at least 1 or 2 extra doses away with them, even if they've got a safe storage box and got all the advice. If they've got children in the house, it's a totally different dynamic than it was just 10 days ago.
Are you seeing patients who previously will have kept their methadone on the lowish side so they can continue to use, now coming into you saying, I think heroin's going to be a bit difficult to come by, please whack my dose up?
Yeah, so those sort of situations haven't been reported to me yet. Right?
Okay.
So I'm not dealing every day with phone calls and patient requests. So I probably, there's a lag between those things happening and me finding out about them. But at the moment, I'm in touch with my prescribers every day, and I haven't been alerted to that sort of dynamic yet.
Okay, so I just want to move on to alcohol. I don't want to stereotype Scottish people as people who drink more than other groups, but you go to Glasgow city centre on any Friday and Saturday night, and there's a lot of people out on the lash. I'm worried whether there's any risk of people who are no longer able to source money through begging or sex work, who are alcohol dependent, going into withdrawal, and what the provisions might be for that group.
Yeah, no, it's a clear risk, and I presume in any area in Britain, but yeah, in Glasgow,
and far beyond as well.
Yes, so we're very, very aware of that. So I'll just run backwards from the sort of highest tier to the lowest. So we're very aware of this. We had 2 inpatient residential units that we delivered ourselves for elective detoxes. We have had to hand one of them over to COVID contingency planning to the board, but we've been allowed to keep one, which is a 15-bedded unit, and we will keep that open for as long as possible. We are going to deal with urgent alcohol detoxes in those settings. So really people at imminent risk of withdrawals, acute withdrawals. We have a long sort of elective admission list there now, but unfortunately those folk are going to go further and further down, and we'll probably take in the more emergency urgent end. And a lot of that is about taking the pressure off the acute system, so people aren't going into acute hospitals with acute withdrawals. So we've got that running in our teams. Most of our alcohol work was done through home visits and home detoxes, and that has taken a huge hit. So what we've written up some guidance for our teams. Scottish Health Action on Alcohol Problems, SHAP, have written up some guidance for problem drinkers about how to manage. We are strongly advocating, that people get thiamine, a low threshold for a camprosate, and we are advising we should try and do home detoxes where we can. If we're struggling to see somebody and they're at risk of imminent withdrawals, we're going to change our threshold for prescribing home Librium for them to manage and try and prevent an acute medical emergency. Basically, not ideal, not something you'd want to do in the normal times. So we are trying to keep those provisions going. That in Scotland, off licenses have been given the okay to remain open.
It's an essential requirement.
It's an essential requirement, yeah. And I think some of that is a recognition of the role they might play in helping people manage their problem drinking over this period.
So I want to ask you, as one doctor to another, how do you feel about informally giving people who are dependent drinkers guidelines on how to detox themselves using alcohol? Not something that we would normally do, but it's possible. What do you think?
Yes. So no, I don't feel. I think difficult times call for innovative measures. I think there's going to be a lot of learning from this. Yeah, I think there's going to be it's not all doom and gloom in some respects. I think we might learn quite a lot about our service users, about our patients, about their ability to cope or not. Yeah. With
And they're
this sort of,
already an incredibly resilient group.
they're
They cope with adversity all the time.
yeah, that's right. And it's really interesting what you say there, because you know, I see people in this service here, in the enhanced drug treatment service, and they just say to me, look, we're still alive. You know, we've dealt with loads of stuff. Doc, don't worry about us. We're okay. We'll be okay. So, and you know what? They may well be the last people standing. But so I think things like advice like that around managing self-withdrawal, I just wonder whether that's actually going to be something that we're going to look back and say, do you know what? People could actually manage this.
I'm prescribing 3.5 cans of Tennants a day, reducing by half a can every 4 days.
Well, you know, the managed alcohol problem proposal in Glasgow is about that in the hostel and homelessness settings.
Yeah.
But yeah, I mean, it may well be that that's something we learn.
Yeah. So I want to wrap this up, but I want you to use your crystal ball now, and I want you to fast forward 12 months from now. So it's April the 1st, 2020 now. In a year's time, how do you think drug treatment services in Scotland and drug policy will have changed, or do you think everything's going to go back to normal?
Well, my biggest concern right at this moment is how many of our service users and our target service users, our target population, are going to survive this. Yeah. Particularly the ones who are the most physically frail, and the ones who are most, in apostrophes, chaotic. Yeah. So that's something that I do worry about, and I do worry about the balance of the intentions of COVID measures versus the adverse impact of, you know, the sort of changes that we're having to implement in that population. So I want to share that, and I think we'll be doing counting numbers and so on, and trying to figure out what happened in this. And I think there's a good little research project, certainly a question in there. So I'm very worried about that. My view is that what happens in Britain is that things default to normal. We're not radical about drug policy and drug policy changes here, I don't think. Okay. In other countries, they may well decide that the further changes are needed. But what I've witnessed over the last few years with regards to our drug consumption room conversation, and the slowness of heroin-assisted treatment conversation, the real sort of lag behind the evidence that exists around some of the legal issues around drug services in particular, or drug policy in particular, do not give me great hope that we'll do anything other than revert back to business as usual when we can.
Interesting. Yeah, I think there's going to be, I think in a year or two, I think it'll be interesting to see where we're at. I have to say, other clinicians I've spoken to are more hopeful this will lead to some lasting changes, particularly if it turns out that, you know, people with problematic drug use appear to respond quite positively and, you know, are responsible with their methadone, and we don't see a huge spike in methadone overdose deaths. And user groups I've spoken to have said this is what we've been waiting for an opportunity to actually be less paternalistic in our drug treatment service, and hopefully for the police and governments to go, what a pointless exercise it is banging people up in prison for personal possession.
So I think that's what I was suggesting, that we can, you know, there's maybe a huge amount of positive learning about this, about, you know, people's ability to self-manage, and you're absolutely right. Those were the terms I wanted to use, about a sort of less paternalistic and even perhaps less of a sort of medical model approach to things. So that I'm mindful of that, and I'm waiting to see that. It's just that policy. So that's at clinical practice level. Yeah. It's at policy level.
Listen, history would tell us that it takes more than really good lessons and evidence to change policy, and it'll probably at the end of the day be an economic argument, and maybe something else, maybe seeing what the rest of the world does. Look, thank you so much for taking the time. I'm sure people watching this will be going, "He's coughing. Is he all right? Are you all right?"
Am I coughing?
Well, you're kind of coughing, clearing.
I was clear. Yeah. No, I've got a bit of asthma. So when I was cycling in, I got a little bit of cold air. That's all it is. Yeah.
Oh, that's good. Okay, well, that's good. So look, in that case, thank you so much. We will probably want to come back and revisit you in a couple of months' time, when possibly very little has changed, but you'll have a better idea of what the real impact has been.
Yeah, totally. I think that'll be really interesting. I think 6 to 8 weeks' time, I'll have a much better handle on how this is playing out. Yeah.
Fantastic. Well, look, we look forward to catching up again then. So until then, look after yourself.
Yeah, you too, Adam. Yeah, and everybody else. And thank you very much for the invitation.
It's a pleasure.
And so the question that you chose to ask, will it be better where we're going? And though the answer I don't know for a fact, still my heart is saying, oh yeah.
Still just taking it one day at a time. Still don't know what I'm trying to find. Really I don't mind, 'cause I'll be fine. Yeah, I'll be fine.